With our last presenter of the day. And I'd like to welcome up Dr. Catherine Reid. She's the Michigan Medicaid Consulting Physician for MDHHS.
For the break, or are we okay? We'll keep open. All right. Here, you have a seat, buddy. Yeah, sit down. Okay. I am Dr. Catherine Reid. I am an anesthesiologist and internal medicine physician by training. I've worked for Michigan Medicaid for the last 6 years. Up until the last 2 weeks, I was on the medical side of Medicaid in the Office of Medical Affairs, the ones that actually wrote the criteria, for our liver treatment. And now, as in a couple weeks ago, I'm over in behavioral health. So one of the things when I was asked to present here, Medicaid and Hep C, one of the things I want to do is take this opportunity of talking to you about how some of these decisions were made. Because I think this is one thing that doesn't really, there's a lot of, from advocacy groups and treatment groups, but there's not a lot of like how we came to be where we were. So that's what I'm really interested in saying. How do I switch these? Just there, okay. Okay, good. All right, so see if I can share this out. There we go. So modern hepatitis C treatment, as some of our other speakers have already talked about, the effective treatment for chronic hepatitis C began with the development of the medication class called direct-acting antivirals, or DAAs. Prior to that, we had really marginal treatment with interferon, ribavirin, protease inhibitors. Painful, didn't work that well, very poor compliance with both the patients, because they were lousy drugs that made people sick. So the first really good treatment was, the first DEA was Gilead Pharmaceuticals, Sovaldi, which was approved in December 2013. Now what's important is I want you to understand what a bombshell this was, not only in the treatment of Hep C, but also what it was to Medicaid. I don't know about the commercial people, but to Medicaid programs across the country. Okay, so immediately when it was released, it's like they planned it, the AASLD and the IDSA came out with a huge guidance document that included Sovaldi and there was a new standard of care. Okay, so the cost of Sovaldi varied by country. Maybe you know this, maybe you don't. A course of treatment in the United States was $90,000. But if you were in Egypt, it was $800. And partly is that because pharmaceutical lobby is an $800 million lobby. And Gilead kind of was one of the first ones to break this sound barrier and just put this test case. They priced it for what the market would bear. And because we have no price controls here in the country. So the impact on Medicaid programs was huge. Initially, when this first came out, the cost estimate from California, which is a much bigger state, has a huge Medicaid population, they were going to spend more on this one drug to treat this one disease than they spent on K through 12 education. So I just want to give you some perspective. So when you're on a budget, like Medicaid is, you can't just pull $200-300 million out of your budget for one drug. And by the way, this now looking back, this was 2014, this is a bargain. We have drugs now that are $1 million per year, per patient, per lifetime. So we're looking back at this, it's like, it was the good old days. It's only $90,000. Man, what were we thinking that was too much? So that's just kind of how we have to look at things, because what happened here, what happened with across the country, is now you then have to go to the legislature and ask for more money. So that's what we did. And it took us, so we immediately started negotiating, again, not me personally, fortunately this is above my pay grade, but you talk about directors and the medical director had to start going to the legislature and negotiate money for this drug to pay this population. So what we had to do was figure out how many Hep C patients we had right now and estimate how many we had that we didn't know about. Because at this time also came the U.S. Preventive Medicine Task Force recommendation that every baby boomer in that, 1945, 1965, get tested for Hep C. So we were trying to do the best we could, estimating how much money we were going to need. And meanwhile, we were covering it on a case-by-case basis, kind of under the radar, because we're physicians. It's a treatment. We wanted to cover it. But so it just isn't that easy. And I think a lot of Medicaid, and again, I don't know about the commercial insurers, but a lot of them, it's like, why are they doing that? Well, this is the best we could do. So anyway, and it took, so we started those negotiations in 2014. It took a year for the legislature to appropriate money for us to pay for this drug. And because, and again, not our legislature, I just want to make that clear. Our legislature wouldn't be like this. But as some of the people pointed out, certain people may have some stigma or some stereotypes or some ideas about certain people who may have like a drug or a disease like Hep C, let's just say. So what they agreed to is that you're only going to have so much money, so they agreed to treat the worst of the worst, the F3, F4. Again, F3 is fibrosis. That means the longer you have hepatitis C, the more damaging it is to your liver. Medivir scores are a grade of damage to the liver. 0 is no damage, 1 is minimal damage, 2, 3, 4, 4 is the worst. 3 is pretty bad. So this is what our criteria was, because this is what the legislator agreed we could pay for. So I just want to put that out there. It wasn't like this is what we wanted to do. We'd have just paid for everybody. Well, we're physicians. We'd have paid for everybody. But this is what they agreed to do. So they agreed on only these. And also our recommendations were, if you're co-infected with HIV, if you had certain other hepatitis C causes other problems rather than just liver disease. They have a variety of kidney functions, bleeding issues that could come, or if you had a liver transplant. That's what they agreed to, and so that's what we started with. And in addition, this, again, stereotypes, stigma, they wanted everybody drug-free, drug and alcohol-free for 6 months, okay? So, and they also mandated an annual report that given to them beginning in March of 2017 that detailed every penny we spent, what type of patient we spent it on, if they had to be retreated, all of this, okay? Every coverage detail, not patient names, but they wanted everything else. So there's just a lot that goes on behind the scenes. It's not just writing a criteria, and particularly if it doesn't involve this much, money. It's really, I mean, this was an incredible bombshell across the country. How in God's name are we going to pay for this? You really have to, because again, if you're going to spend $50,000 on treating this Hep C person, well, then that means some child with cerebral palsy is not going to get their customized wheelchair that they need. It's everything's a trade-off. And then also, your roads aren't going to get fixed. Just want to throw that in there. Okay, so our current coverage criteria is 18 years of age. Now, 2 of the drugs are now indicated for 12 years old. Now, I'm not exactly sure. We have been covering them. My own personal opinion as a physician is that anybody 12 years old, it doesn't matter what other things they may have going on. Hep C, if they've got Hep C, they should be treated because most of those are going to be congenital, and that is a different disease. It moves much faster. So if they got hepatitis C from when they were born, they're now 12 years into it. So when they hit 20, they're going to be really sick. So that's my personal opinion. Again, I don't work in that department anymore. But most of us were thinking like that, so I don't know what the final decision is going to be, if they're going to just automatically rubber stamp. You're 12 years old, you're covered. Diagnosis, of course, has to be chronic hepatitis, because once in a while we will get one that is, well, I'm not sure this guy, he has hepatitis for sure, but I think it may be acute still. I'm not sure that this is really chronic. And they have to document an RNA viral load. Genotype must be documented. To get the initial. Now, the other things that'll get you an automatic approval, if you're co-infected with HIV, if you had a liver transplant, and also basically, it's not in our criteria, but basically if you've had any kind of transplant, real stem cell transplant, kidney transplant, we cover it. serious extra manifestations like the cryoglobulinemia, the glomerulonephritis, or so if you have one of those, you're automatically covered. Otherwise, you have to meet our criteria set by the legislature of F3 or F4. Now, because after doing this for a year, so we got to fall 16, and it looks like we had a little bit more money than we hadn't spent as much as we first intended to on our first, calculations of what we were going to need. So we, without asking permission from the legislature, expanded to F2. We wanted to also expand to all pregnant females, but we weren't allowed to do that. They said, let's go for the F2. And believe me, we heard about this when the legislature found out. I mean, this was, there's tight control over this money, and they were not happy that we expanded to F2 all on our own without asking express permission from them. So, and then there's a variety of ways, as some has been discussed. There's serum markers, there's imaging, there's velocities that you just look at the liver from different machines, what will give you a score, a scarring score, liver biopsy, looking at ultrasounds, MRIs, CTs, scopes, and basically there's lots of ways to arrive at this scarring score. Okay, now this is the other thing that was in agreement with the legislature to give the money, is you had to be a physician, a subspecialty physician, you had to be a gastroenterologist, a hepatologist, a liver transplant specialist, or an infectious disease subspecialty physician to write these drugs. That means I couldn't write this drug either. And if you weren't one of these, then you had to be working with one of them. And that includes all internal medicine physicians, all non-specialty physicians, every nurse practitioner, every PA. And then you had to document who you were talking with, that you discussed this patient with them, they agreed to the treatment, and they signed off on it. I'm not sure if this is going to change or not. Clearly now, like I mentioned before, the drugs have gotten a long way in 3 years. They're stronger, faster, better, and cheaper. Sovaldi was a 12-week course. Now we're down to drugs and Sovaldi was a little bit optimistic when they talked about their cure rate. When they launched, they're like, 90% cure. It's like, yeah, they had a variety of studies. Their pilot research studies had 10 people in them, 21 years old, Hep C, nothing else. They had no other medical issues. Yeah, I imagine they did do a little bit better. But so they were a little bit optimistic in their success rate. And even as physicians, we were talking, if I had Hep C, I think I'd wait for the next one that's 100% successful, and you take it for 2 weeks. Well, we're essentially there. So the whole commercial pharmacy of Hep C drugs has improved to the point where they're cheaper and they're better. And you don't take multiple drugs a day. You take one pill and you take it for, I'm not sure any of them are down to 2 weeks yet, but they're definitely down to 4. And I'm not sure what's more in the pipeline, but they're much better drugs. They work better. They have fewer side effects, and just better for everybody. So I'm not sure if that is going to be loosened up to just more people can apply for it or prescribe it without this kind of backup. What else was I going to say? So the main thing clinically with these Hep C drugs now is resistance. So that's, not that they don't work. They do work now. They work better. But you're still getting an issue with resistance. I can tell you, anyway, so I'm not sure if that's going to be changed. Right now, the current director, the medical director is not in favor of a change of that the last time he spoke about it. So I don't know where we're going with that. So these are our current medications, and I didn't want to do a lot of clinical stuff here. This is what we covered, basically everything on the market. Elycio is going off the market. There's just better drugs that it just doesn't work that well, compared to the newer drugs. So that's going off the market. And also, almost nobody prescribes Sovaldi by itself now. It's in combination with other drugs. It's much better in combination with other drugs like Harvoni was mentioned earlier. So Alecio, basically nobody writes for that anymore, and it's going off the market. And then Tecdivi also is going off the market. It has Alecio in it. It's just not that. It just doesn't work that well. There's better drugs. So that's going out the market. And then there's these other ones. So we basically cover all the DAAs, the direct acting antivirals, which is the modern therapy. I mean, nobody's using interferon anymore. Nobody's using ribavirin, and the other drugs, the protease inhibitors, they're off the market. So this is what our latest, this is as of in June. This is how many people we've treated so far. And as you can see, Harvoni, which really has it's a great drug. That's been the most, and we still have only approved a total of 300,674 approvals for 3,415 patients. Now, part of that is because retreatment through a variety of issues. They're retreated because, they never followed up. They got the first round, they never came back. It was a treatment failure. So there's a variety of issues there, and all of that is better discussed in the report that has to go to the legislature. And I helped write the last one, but it didn't have anything to do with this one. So this is the one that was due this year. So I'm happy about that. So this also, of these approvals, I didn't put it in here, but there was about 700 of them that were first denied and then approved. We have another 1,400 that were applied, denied, and stayed denied. Most of those were because they were either 0 or a 1, an F2, an F0 or F1. They didn't have any of the qualifying things. A lot of it, as part of it is the paperwork. It's like, we also prior authorize a lot of the substance abuse treatment. There's paperwork you have to have. Like if you submit something, a couple slides back where you had to have this stuff. If you submitted a request, you didn't have the genotype on there, you didn't have the RNA, it's like, well, that's going to go back to your office, and you're going to give us that stuff. There's certain things some things can be made to slide, some things that we really have to have. So, okay, now we get to the Hepatitis C lawsuit. When we started our coverage, we were pretty much middle of the road for Medicaid programs. There was very few, I think there might have been 2 programs in the country that opened up to anybody, that 0 through 4 could do it. Most people were where we were. 3s and 4s was very common. Some places only 4s. And I was at a conference where John Koster, who's the head pharmacist for CMS, which is the Centers for Medicaid and Medicare, and he gave a little speech. This is probably 2 years ago, about how states are handling Hep C, because some states really weren't covering it at all. I mean, they were covering it on paper, but they really were denying everybody. We were actually doing pretty good. And like I said, we were covering it from the beginning, just on a case-by-case basis, until we got the approval and the money from the legislature. So there was many lawsuits, as probably at least 20 states have been sued. And depending on what they were sued about, some of them immediately went from covering only 4 to covering everybody. There was a variety of specifics with the different lawsuits. Ours, I'm not actually really sure because I was not directly involved in it. So, but ours was a fairly small level. But two of the changes that it did bring about, and there's going to be more things when the final settlement comes through, so there'll be a bigger announcement in the fall. But the 2 things that for sure is happening, that this October, we're dropping it to F1. Next October, we're dropping it to F0. So that'll pretty much open up for everybody. And hopefully, since there are many more drugs now, the cost of these drugs has gone way down. There may be a possibility that this will be changing even a little bit more. I don't know. This did, in a conversation about a month or so ago, this did come up. Well, if we've got the money for it, can we just drop it now? And it was like, no, because that's not what the suit says. So it doesn't make sense to me. But then, I'm not a lawyer. So right now, that's the plan right now. How much more we're going to change or open it up, I'm not sure. But those 2 things are going to happen. And I don't, we'll have to look at the budgets, and, I don't know if we can get it even open it up to F0 opens it up to everybody. But one of my questions that I answered what I was given is that we can't do it until October 19th, October 2019. But that doesn't make much sense, but that's what I was told. So right now, what we're concentrating our efforts on right now is that we're trying to work with population health. This is Joe and Katie. And we're trying to, one, improve surveillance of health outcomes. We're trying to get, because Hep C and HIV for that matter too, of course, is a reportable disease. So if somebody is tested out in the hinterland and that test comes back positive, it goes to Joe. So what we're trying to make sure is that, okay, well, let's see if we can follow up that this person had a positive Hep C test. Did this person ever get treatment? So we don't want people who were tested positive and then never either deliberately didn't want to follow up or just didn't get follow up. Now that's some complicated because it has to be data use, exchange information for our Hep C patients, names and numbers all have to go in there. So that's one of the things we're looking at. And then two is, well, I already said that, but the other thing I should have put up here didn't is trying to follow up. Basically, this all become Hep C and HIV also have all come part of a bigger harm reduction strategy. So to really tie in, a lot of this is being tied in with SUD treatment. So we're looking at substance use treatment, HIV, Hep C. So which is really where you want to be. It's a more global harm reduction, process. So I think that's about all I had. There was one thing you sent out an attachment this morning from the Hepatitis C roundtable up from Harvard. Yeah, I just want to make one tiny little comment on them. They published a report about 3 years ago, and this is when I was actively engaged with all the other Medicaid programs. And I remember in a meeting was like, did these people ever talk to any of you? They had not talked to one Medicaid program. Apparently, they just got a lot of their stuff off the websites, which is not necessarily all that helpful. So there was a lot of misinformation in their reports. So anyway, I just want to put that out there. They would not be my first source of places to go for information. So anyway, so that's about it. Any questions? Yes. Mm-hmm. Yeah, that's a problem. That's one of the things that we're working on, and as part of the follow-up of finding places for everybody to go. Whether or not we're going to lower that so that anybody can treat, I'm not sure. That's definitely something that needs to be discussed. And again, it's not as complicated now as it was even 3 years ago. It's much simpler. The drugs are better. And the only thing you have to worry about now is resistant. So, and the other problem with Medicaid patients is that we don't pay anything. We pay nothing. We pay as low as $10 for an office visit. So that's why people don't like to see Medicaid patients, because what we pay them doesn't even pay for the light bill for the time they're going to be at the office. And that's a huge problem. I'm not sure. I know there's been some talk about, because we have the same issue with substance use disorder, and that maybe we should pay them more. But then again, you got to go back to the legislature, and it's all going to be budget. You have to have permission. You have to write waivers. You have to change state plan amendments. I mean, it's not just like, that's a good idea, we should do that. It just doesn't happen like that. So I would probably, the best person to contact, now this is the payment of Hep C medications is taken out, it's called carved out of the health plans, which means we just carve the costs out of the health plans and we pay for it. So we wrote the criteria and we pay for it, and we do all the prior authorizations, and fee for service does all that. But one of the things that in the last year we've really made a push for is for the health plans to take a more active role in case management, including making sure people get referred. So if it is a health plan person, you really need to lean on that health plan, because that is their responsibility. They're not paying for it, but it's still their patient. It's still their responsibility to make sure that patient's taken care of, and also to do the case management. We pay them for case management. That should all be part of it. We also pay for transportation, because many of our Medicaid patients, transportation is a huge problem. We pay for that, but somebody has to set it up for them. So that's one of the things. Where else, Joe, what else should we talk to? There's provider support. There's, other than health plan, if they're fee for service, you can call fee for service. If there's a health plan, you need to lean on that health plan, because that is their job to get that stuff done. We pay them for that. Did you have another question? Mm-hmm. 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 Yeah, I would probably say legislature. Of course, this is lame duck legislature, so the people who set this up are all either gone or on their way out. The other thing would be just pursue. You could pursue us. I mean, I'm just not sure that's going to change, because there have been mistakes. Several of them, and if you pick a medication and not everybody dispenses it like you do at the FQHC. A lot of it is sent to the patient's home. So if you decide a week later, we got a prior auth for that same patient for a different medication, I changed my mind, that's $50,000 out the door, gone, because you can't take that medication back. And it's like, well, why didn't you think this through the first time? Well, I just changed my mind. It's like there's been mistakes like that. So I'm not sure how that's going to go, but it's certainly, but again, I couldn't prescribe it either. I'd have to have a backup, with one of these specialty physicians. So I think the Medicaid director right now, who was present for most of this, he retired. He left for another job last year. We have an acting director now. So she's unlikely to make any decisions like that. Our medical director is currently Dr. David Neff. He would be part of that decision-making process. But I think but just from being on this side of the legislature, talking to the legislature is something that, can be effective if you can get their attention for something like this. But we'll take it all in consideration, because there'll be more. Like I said, we're really trying to make a much more collaborative effort now between everybody, and helping to write this report that has to be done to the legislature every year. They've got disease surveillance, they've got some numbers, so we're trying to pull it all together so we can see everybody tested, did they go get treatment, and we can also work on, and it's not the only time I've heard, the Northern Michigan and the UP is very difficult to get a lot of stuff done.
Docs, and there's no infectious and the ID docs that there are, they're attached to a hospital system and won't take the risk of signing.
Yeah, they don't want to. Yeah. So it's hopefully there'll be a better way. So, yeah.
I was just going to say to Pam, I think the Office of Rural Health,
Yeah.
planning that they're going to be doing soon is going to get a lot of attention. I think there are already a lot of legislators involved in that process. So incorporating telehealth into that.
Yeah, telehealth.
Their recommendations is going to be really important.
Huge.
Don't get short-sighted about opioids or drug treatment or Hep C. It's just a telehealth issue for all conditions.
Yeah, I forgot about that. Yeah.
You just need telehealth, and that Office of Rural Health, that's going to be a big deal. That gets a lot of.
Yeah, because that would be a huge help. Yeah. And I forgot about telehealth. We're really, because Michigan, we use it, but we don't use very much of it. There's other states that are much more down the road in using telehealth than we are. But something like that would be perfect. We use it's probably the most telehealth we use now are psychiatric. But there's that, we're looking to expand that. Plus also, we work with other things like CDC. They've done a county by county risk assessment. So that helps too, because we can help, again, try to funnel more resources to underserved areas. adults. And as again, anything above Gaylord is pretty much rural, underserved area here in Michigan. So, but yeah, telehealth will be a good one. And that, and there's a lot more movement on that right now, trying to broaden our telehealth use. Mm-hmm. Anything else? Yes.
This question is in reference to the lawsuit.
Mm-hmm.
And I was curious how they were going to break down the difference of F0s and F1s in the scoring, because some FibroScans, FibroSure testing lump F0s and F1s together.
Right.
Right now, FibroScan's at a 7. What does that mean for F1s?
Right. And I left out those things. Yeah, it kind of depends on, and we've changed this several times. There are more uniform standards of what is accepted. And I know when I was approving these things, I tended to give people the benefit of the doubt. Well, that's pretty close. Let's just prove that. But yeah.
Round up when I
Yeah, just round up. That's pretty close. It's the same thing with the sobriety things. It's like, if there are certain cases that are very straightforward that our call center could cover for us, and then they would send it to us when there was a question. And most of those we just approved because particularly they had to send us and say, well, he drinks like 2 beers on the weekend. Well, that's pretty okay. But it is, and as it's been talked about before, it's very hard when you're trying to explain to the legislature as to what you did and who got paid for retreated. If you have somebody that, who says right there on the progress note, I drink a gallon of vodka a day and I'm shooting up every single day, multiple times with multiple people. It's really hard to explain that to a legislature that, we want to cover that, when they're still talking about when you're trying to cover other things too. So, but we've tried, I can only speak as one of the physicians doing the approvals. We tried to be kind of as lenient on that as we could.
Like type 2 diabetes and childbearing age and certain.
Well, no, there's certain things we couldn't. And if the only thing you had was that you were childbearing age, we couldn't do that. We couldn't go that far. We wanted to, we couldn't. You really had to have one of those markers. And then we could fudge on the sobriety part, but you could not just come out of left field and somebody who's like an F0 who is childbearing age, which, what would make more sense than to treat somebody like that, we couldn't do it. Because one other thing that you may not know about Medicaid, we're audited. We're audited all the time by the federal government, and constantly. Every part of Medicaid is constantly being audited. And if somebody saw our standards and then saw that we treated an F0, because she was pregnant or we're going to have a baby, they would take that money back. We would get in trouble, and they would take every penny that we had paid to everybody involved. They would take that money back, because that's the rules. So so we couldn't go that far out, but we would kind of be as lenient as we could.
Right, because from my experience, it's kind of been a case-by-case kind of.
Yeah, and it also depends on who's looking at it, but.
There's so many inconsistencies with people that review these sometimes.
Mm-hmm. Well,
that can be so frustrating.
With Medicaid, you've got 2 sets of people reviewing it. You got the pharmacists at the call center, and then you got the physicians in Office of Medical Affairs.
Physicians are there that are reviewing?
That are doing pharmacy right now. It's just changed because there was 5, and now there's 1, 2. I've left. So at this particular second, I think they're down to 2. And as of a couple weeks ago, because I just now made this move. And they're part-time contractors. They're not full-time.
Right.
Yes. One of my other concerns is they say they have to be free of drugs and alcohol. Well, I've never met anyone that contracted Hep C from smoking weed. Why?
But
Why is that?
one of the reasons, well, one is because that's what the legislature told us to do, but also, again, everybody's being painted with the same brush. Well, if you're smoking weed, you could be God knows what, or if what if you were smoking weed and you forgot to take your meds? Well, then you're not being treated, then,
I've had patients with a diagnosis, which I send a summary sheet with diagnoses of ADHD and on Adderall, and they get denied.
I can't tell you that, because that's never been,
Case by case.
ADHD, Adderall has nothing to do with it. I don't know why anybody would be denied for that. There was probably, no, that's not part of any of our discussion. So I don't know, there was probably something else about that got it denied. Something else in
That was
the, well,
That
I
was
can't
the
tell
whole
you.
reason. But that's what I said, there's so many inconsistencies on why
Yeah.
it was denied.
That one's new. We never ever talk about that, anything like that. So I don't know if that's what somebody wrote on a denial.
Yeah,
And I don't know if that's what
We
the
could show
pharmacy did, but I can tell you, that's not something that was ever discussed.
It's just so many
Mm-hmm.
inconsistencies. It's frustrating.
Yeah, I think
Follow all the rules and then
we
they-
did.
She doesn't send them to our pharmacy unless they meet guidelines in some way.
Yeah, I can't tell you. But some of the ones that are doing it now and have been doing it for the last few months are their contractors. They're not in-house all the time. So it's because I was there for 6 years, so I was in from the beginning of this. I was in all the discussions. You learned all about Hep C, more than I ever thought I knew. Just like kind of like the Flint. Now I know a lot more about what goes on in water pipes now than I ever thought I would. But of course, Hep C is much more important to me. I'm a physician. I knew a lot, but I know a lot more now. Just when Sovaldi came out, and I knew a lot more about the process. But I don't have an explanation for that. I've never heard anything like that, and I would never ever have denied anything on that.
Yeah.
So, anything else? No.